Okay, so this is my first case. The patient has had a total gastrectomy. You can see that their stomach is gone. They have an esophagojejunostomy. And this is a follow-up scan. And we were looking for any metastatic disease. So we always want to look in the region of the lymph nodes that, they resect all the lymph nodes around the stomach, but we want to look around the celiac axis where, I don't know, we don't see good fat planes here, but I'm not sure, there's definitely nodes there. There is this one aortocaval node that's a little bit suspicious, but the finding that was new from the prior exam is that there is new hydro and there's a little bit of thickening along the ureter here. So what would you guys call this?
And patient has a known malignancy, right?
Yes, they have a history of gastric cancer with a total gastrectomy.
Yeah, I mean, mets to the urethral wall are, I'm guessing, very uncommon, but that's one thing I would think. And then, of course, rule out infection or primary urothelial malignancy itself.
Okay, good. Excellent. So yeah, this kind of urothelial thickening, I would say, like if the patient didn't have a history of malignancy, maybe we would think about like pyelitis, infection. But I guess this is one of the teaching points I wanted to make for this case is I've seen several cases with, especially when the patients have signet ring cell or gastric cancer or lobular breast cancer, that it can metastasize to the ureter and it can be very subtle. And the only finding, sometimes you might only just see hydro, or you might see this enhancement along the wall here. I've had a couple of cases like this and they had to, it's very hard to actually, prove that. They might even have to go to the OR to prove it. Sometimes it's hard to even get it on ureteroscopy because it's in the wall. But this patient got a PET MR and show you. So this was the PET MR. And actually, I'll show you the MR too, but you can actually see now that there's some uptake along the hepatic capsule. And there was actually like a thickened rind of enhancement along the hepatic capsule. This PET MR was about 2 months after that prior CT. We can also see that some lymph nodes are lighting up, like this one. And then that aortocaval node that we saw previously has gotten bigger and it's avid. And then interestingly, the ureter was not very avid, but it was mildly avid. So we were hoping that this would prove the ureteral involvement. This didn't necessarily do that, but we can now see that there's definitely lots of metastatic retroperitoneal lymphadenopathy, as well as peritoneal disease along this hepatic lining here. And let me just pull up the MR and show you the... So here on the coronal, we can nicely see that there is this enhancement along the hepatic capsule. So always look at the coronal if you're looking for peritoneal disease. It can be subtle, but this is basically all, FDG avid as well. So this was metastases to the capsule and basically peritoneal disease. You can also see the peritoneum here is also enhancing. I see there's some people. Oh, Christine says she has one and Roopa also has one. Great. Okay.
This is interesting. Aarti, the peritoneal thickening is so uniform. Normally metastatic disease, the peritoneal thickening can be nodular, irregular, but this looks so uniform.
Yeah, and I think that this to me is sort of like the signet ring cell gastric cancer and the lobular breast cancer. They grow in like kind of this like sheet-like pattern. Mm-hmm. They don't have they lack like EK adherence. So they can even grow in the liver, just like kind of infiltrative, not really like a mass. So I think that's why it looks like this, but it can be very subtle, like on CT especially. But whenever I see new hydra, I always get concerned, especially with gastric cancer. So it can be retroperitoneal. It can also be peritoneal disease. And this was FDG avid. So, I mean, we're still presuming it. We don't have like a biopsy of this or anything, but yeah, the patient, had all those other lymph nodes as well too. Okay, this is my next case. This is a cool case. I want your input. We can see that the kidneys, this one has like some scarring. The main finding is in the pelvis. Patient was presenting with pelvic pain and feeling of heaviness. They're in their 60s.
Wow, these are some of the most florid pelvic varices I've seen. Wonder if it's an AVM.
Yeah, so the question here is this, pelvic congestion syndrome? We actually see this huge gonadal vein here. So draining into the IVC, this right-sided gonadal vein is very large. And initially, this was called pelvic congestion syndrome with lots of varices. But like you said, actually what this turned out to be was an AVM. And one of the clues is you can see how large the iliac arteries are, and they're feeding some of the vessels here. But I still think on CT, and you can't really necessarily like prove it, but the proof would be on angio, where they see that the arteries are supplying this. It's not just dilated veins or varices. So let me see if I can, sometimes this, oh no, wait, sorry.
Another thing that comes to mind is usually pelvic venous disorders, as they're now called, the left gonadal vein starts getting dilated first. And then when the pressure can no longer be sustained by the ipsilateral dilated adnexal veins, it then crosses over to seek drainage from the right side. So here it seemed almost like the right gonadal vein was larger than the left, but I mean, that's just a thought.
Exactly. So that was one of the things that the IR person who was looking at this case noticed and said exactly what you did, which is that this is not the typical, usually it's that left gonadal vein that's very enlarged. So this was the angio. So we're in the aorta and you can see the large iliac arteries, and then you can see these huge uterine arteries. Oh shoot, it froze my screen. This happens sometimes if I bring up an angio. But anyway, so this was a huge AVM. So they ended up embolizing the uterine arteries, which is what they do to treat AVMs. And on the post, it was significantly, like all of the vascularity significantly reduced. So I wanted to show one thing, which is sometimes when we talk about uterine AVMs, we wonder if if a patient, for example, is postpartum or post DNC, how can you tell the difference between RPOCs and an AVM? This radiographics article shows basically, for example, this is florid RPOCs. It looks very, very vascular. You could see how you could mistake this for an AVM. However, you can see it's going into the endometrium here. So the AVM will be centered within the myometrium, whereas RPOCs will extend into mostly be in the endometrial cavity. You can see this is the endometrial cavity. So this is a large RPOCs in the endometrial cavity. The waveform also, usually AVMs will have higher velocities and more diastolic flow. So this RPOCs did have pretty high velocity, but not as high as an AVM usually is. And then they show an AVM here. And they say basically you can see that it's within the myometrium, not within the endometrium, and it's going to have very high velocity, low diastolic resistance flow. Let's see if this is still frozen. Yeah, it's still frozen. So I'm going to stop sharing. Do you guys have any comments about this uterine AVM case?
Beautiful. Hopefully the patient is doing well.
Yeah. And actually a couple of other comments about uterine AVM. So they're pretty rare. Most of the time they're acquired, not congenital, and they're acquired from prior trauma, like a DNC or some kind of uterine manipulation. This patient had a DNC 30 years prior. They said there was a lot of bleeding at the time. And so I don't know if there was maybe a smaller AVM at the time that now is proliferated, or that DNC caused this AVM. We'll basically never know. But in the literature, it says that they're usually not congenital, they're usually acquired. So maybe that DNC had caused this, and then over 30 years, it caused it to become larger and larger. They also said this patient, they wouldn't do surgery on this. This would be very, very high risk for bleeding. And that, just the uterine artery embolization is sufficient. Okay, I'm going to stop sharing.
And then she had pelvic heaviness, right? Not menorrhagia.
Yeah, exactly.
Yeah.
So normally AVMs will present with bleeding, but this one, she presented with heaviness, and that's why also they went down the pelvic congestion syndrome route, but it was actually an AVM. So she was lucky. She didn't bleed. And also she didn't,
Yeah.
she didn't have a catastrophic bleed from this. They were able to embolize it before then.
Nice.
Okay. So who wants to go next? I have Christine, Roopa, and Anu.
I can go last. Mine are simple, straightforward show and tell. So I'll
Okay,
let Roopa
Christine,
and
why don't you
Christine.
go?
Okay. So, like I said, this patient presented for just evaluation prior to UFE. You can see that she's got multiple fibroids. But the reason I wanted to show that was because like after UFE, she basically developed this disseminated peritoneal myomatosis picture. You can see that a bunch of the fibroids are now non-enhancing, but there's just like a bunch of basically extrauterine.
Wow.
It's like all over the place. So I just wanted to know if you guys have experience with that. The only thing I found when I was just looking back at the prior, so this is the prior from 2018, is that perhaps like there were some small like peritoneal leiomyomatosis or leiomyomas back then, and for whatever reason, maybe just the way the arteries were embolized, like now all those leiomyomas have just exploded.
This makes me think about those like locally aggressive invasive angiomyomatosis. I mean, leiomyomatosis. Like I had a case that was invading the vasculature.
Wow.
Sorry, it just made me think about that variant.
Yeah, I think there's a couple of fun fibroids, like some that invade the vessels and others that are disseminated like this, like peritoneal. But I have never seen it proliferate after a UFE, but I think that's a great theory because now like all the vessels, all these other fibroids are devascularized. So maybe these peritoneal ones were able to recruit more. I can't really imagine that it like disseminates it in the sense, like when the morselization, they used to say like they don't do that anymore because that can disseminate throughout the peritoneum. I can't really imagine how a UFE could do that.
Mm-hmm. Yeah, I've just never seen anything so extensive. It actually goes all the way into the abdomen as well. But yeah,
it's crazy.
Cool. Okay, Roopa?
Yes, Aarti.
You want to go?
Let me screen. Yeah, let me share screen. Okay. So this was a patient who came in for a GI bleed recently, and we didn't see anything related to GI bleed, but I have okay. So that's the area of interest. Not hard to see. But what kind of differentials would we have normally given for something like this?
Melanoma. I mean, metastasis.
Cancer.
Just
adenocarcinoma.
Okay, all good. And then additionally, if I told you the patient has
neuroendocrine
history of
tumor.
HIV.
Oh,
sure. Any kind of malignancy, primary, colonic, mets to the colon, all good. Additional history we got was that he was HIV positive. Would we add anything? Would we change anything?
Kaposi sarcoma. Wait, what's his CD4 count?
It's low. It's
Kaposi?
very low. Kaposi's. What else?
Actually, what is that stranding in the left retroperitoneum?
So this was an art line. They tried to place and give him some.
I was like, that's Kaposi's.
That's a distractor. I know. There were no, so just to complete the rest of the scan, there was none of that hypervascular lymphadenopathy we see with Kaposi's anywhere. No other concentric bowel lesions we saw anywhere else.
I mean, we always think about infections, but like TB, usually that's like near the ileocecal valve.
Sure. That's a great thought. Again, in immunosuppressed people.
But I haven't seen infection be so focal mass like this. But well, I guess
I know,
TB
right?
could be. Yeah.
TB, and one other infection they talk about that can be mass-like this is amoebiasis, where they form amoebomas in immunosuppressed patients. Again, those are more common around the IC valve. So those were kind of the differentials we gave also. So patient did get endoscopy, biopsy, and this turned out to actually be CMV-colitis induced pseudotumor. So it was not a malignancy as we feared. So it was just a CMV-colitis that was presenting as a pseudotumor. So I just have a few things. I had not heard a whole lot about this entity. So I don't know if any of you have seen or heard of it before. So they say it is something that can happen anywhere along the GI tract from the duodenum to the rectum. And any sort of immunosuppressed patients can get it, but HIV ones with low CD4 counts are the ones at most risk. We've seen the typical CMV colitis that we know how that looks like, but when this organizes over time, it causes this mass-like appearance, and they treat it with 4 to 6 weeks worth of antivirals. So these are some scope pictures from an endoscopy journal that I found. And this was nice. This was an MR case, which they showed in one of the radiology case reports where there was circumferential mass-like thickening. So this we would probably call some sort of an infection, although some of it looked a little aneurysmally dilated, thinking about lymphoma, but not very homogeneous enough, I suppose. And this is a month after treatment where all that thickening resolved and there's just a small pocket of air from a microperforation. So other differentials, like Aarti said, Kaposi's. So we do look for bowel wall edema. If it's in the early stages, you will have ulcers and hypervascular nodes. Lymphoma, of course, higher risk in these HIV patients, and then infections like TB. And this was just an uncommon site being the sigmoid colon. So something to add to our differential when we are seeing immunosuppressed patients with bowel lesions. That's all I have.
The bath report.
I know, right? Best thing it could be for anybody.
I was just Googling to see if HIV patients have a higher rate of colon cancer. And what I found was that in general, they have a higher rate of malignancy, especially liver cancer, anal cancer, and Hodgkin's lymphoma. But they do not necessarily have a higher rate of colon cancer. So they have the same screening guidelines for them.
So liver cancer,
That's
is
good.
they specify HCC cholangio? Or they don't
I'd have to look
specify?
further. I can get back to you.
Yeah, no worries. I'll search as well.
I have a cute case.
Okay, go.
Okay. Abdominal pain.
Is that a duplicated gallbladder?
Yeah, isn't that cute? Here, let me
So
show you the
cute.
MRSP images. Here's the MRSP. So here's one of the cystic duct right here, right there. And then the second one, right, just cranial to that, right there.
Very cute.
Super, right?
And one has a stone and the other one is normal.
Yeah.
Cute. Cool. I've been waiting for one of those. I tend to get the hourglass gallbladder and, you know, like with the ring of adenomyosis in the middle, but I haven't had it duplicated. Anu, you want to go?
Yeah, sure. Can you pause recording, please? 3 simple things. This is a middle-aged woman who underwent LAR. She had a history of cervical cancer, and then she had some discharge through the vagina. And so we did a fluoro study, and you can see contrast being injected through the rectal catheter. And then sure enough, there is significant spillage of contrast through this recto-vaginal fistula outside. So this is just a fluoro demonstration of an iatrogenic recto-vaginal fistula. And then my next case, can you pause recording again? There's no guarantee
Anu, I have
that.
a quick
Yes.
comment on this.
Sure.
We've had cases where we suspected on MR and clinically they suspected, but we've kind of not been able to prove it on gastrograph and enema. And I've done a couple of times where I've actually put the catheter in the vagina And I'm curious about what people's thoughts are about whether or not you should start with the vagina or the rectum. And the reason I think sometimes it's better to go through like the smaller cavity is like you can get more pressure, but I'm just curious what other people do or start with.
We usually start with the rectum, but others can chime in as to what they do.
So we start with the rectum too, and we've not been very successful though.
Maybe
But have
then,
you tried the other
yeah.
way too? Like, so I think I would still start with the rectum, but then if you really suspect it and you can't get it, I have had a couple of successful ones where I've put it in the vagina. And it's kind of like when you do like, if you're looking for a fistula between the bladder and the rectum, I'll start with the bladder because you can get more pressure. And so if it's like
Right.
a tiny little fistula, it'll go that way rather than like up the colon, like path of least resistance.
Yeah. So do you use a Foley and occlude the vaginal orifice? Because that's bigger and therefore generating enough pressure is more challenging, right?
It is. And it is harder if they've had multiple births, but
Yeah.
I have been able to do it. So
Nice.
Yeah, for the vaginograms that we do, we have I'll have to look up the name, but it's like a flat disc. So it's not a round like the Foley balloon, you know, where you,
Yes.
but it's like a flat disc that we insufflate so that you have a closure of the intratus.
Nice.
Yeah.
So the disc is collapsed and then you insufflate it just like inflating the Foley balloon, right?
Yep. And then the patient just keeps it in place with her hand.
Mm-hmm. And then what do you do vaginograms for the same indications?
Yes.
Recto-vaginal or vesico-vaginal fistula?
Mhm.
Okay, nice.
I seem to be doing some high-level fluoro at Mayo.
Yeah, exactly. I'm going to look up that.
I'd love for you to share what advice is, Nelly, because every once in a while, if it comes up, it probably, by the time the next one of mine comes up, it'll expire on the shelf and I have to throw it away. No, that's the problem. But it'd be nice to know what that thing you describe is, Nelly.
Let me ask our tech. I learned how to do it here at Mayo. I hadn't done one prior.
Nice.
Steve,
Dan
your
Johnson
patients could
taught
also
me.
just drive over to Scottsdale. That might be easier.
The drives are long drives, even if it seems close on the map, it's not. It's not like New England where you can get from town to town in an hour.
Exactly. Yeah.
All right. So the next patient is a 67-year-old lady, multiple comorbidities. And during her current, this is a CT from October, but during her current admission also had COVID pneumonia. Rare, right? But anyhow, I'm going to show you the current scans. But before that, let's look at this October CT, where on the sagittal, as you can see, there's some fecal material. And this is her anorectal angle. That's the anal canal. So the reason I'm showing this is because we got a request for an MR to look for a recto-vaginal fistula. Okay, and when we looked more into, we protocoled this study, and when we started doing it, the tech called us. So here is the axial T2, and the tech called us saying, I just can't hold, I cannot inject or insufflate or inject enough contrast through the rectal catheter. Everything seems to be coming out. So we were like, oh, maybe it's a huge fistula. And then the patient couldn't tolerate the study, and so we had to take her off the table. So the only sequence we got was this one, which is an axial T2. But as you can see, there is the bladder is distended, but then within the rectum there's air, and we have very little contrast, but we do see contrast more anteriorly. So then I reconstructed it in the sagittal plane. And what I noticed is, indeed, there is a huge defect. And, whatever is coming out while the tech is trying to inject contrast into the rectum, sure enough, it's spilling out through here. But this is her bladder. That's the urethra. The vagina is here. And this seems really low. We couldn't see the vagina separately on MR. Of course, the resolution is poor. This is a reconstructed image. So what we did is we went back to her December CT, and I'm going to pull up the sagittal images here. And if you can see, we see the same finding. This is the anal canal here, because remember I showed you the October CT. Here is the anorectal angle, but there seems to be a huge defect and all this is pouring out anteriorly. So what we realized is that the vagina is nowhere in the picture. She had a hysterectomy previously, and this turned out to be a recto-vaginal fistula, not vaginal, recto-cutaneous fistula. So basically,
Did she have trauma before?
yeah, so coming to that point, there was no history of any instrumentation, no trauma, nothing. The only history that was solicited was persistent constipation and stool impaction.
Yeah, I was gonna say, Anu, in that last CT, it looked like a lot of stool in there. So maybe just like from chronic pressure.
Exactly. That's what we concluded is, stool impaction and maybe hypoxia, ischemic damage to the rectal wall, and then development of a large rectocutaneous fistula. We couldn't come up with any other meaningful explanation for this, but the defect was huge. They went in and they noted it as well. They didn't have to go too far, as you can imagine, to find that opening.
I was just gonna say, after all this imaging, they probably could have seen this clinically.
Yes, indeed. But
It's a good reminder to eat our fiber.
yes, and also we hadn't called it on this CT. Like we must have read it and didn't give too much thought to it, but if something doesn't look like it's going the right way, give it a second thought. And then
Sorry, what was the history on this patient?
So during her current admission, they said she has a recto-vaginal fistula and she's pouring stool from the anterior perineum. They probably didn't examine her because she had a lot of comorbidities. She was admitted with COVID pneumonia. So I wondered if they actually tried to figure out where that stool is coming out from, just the perineum, or indeed, like, is it from the vaginal orifice? So that's the history we got. And this is just a nice depiction. Of course, MR can show us these recto-vaginal fistulae nicely. History of Crohn's in the past and development of a chronic fistula. Look how narrow and delicate this tract is. But you can see there is T2 hypointense fibrosis in the space between the posterior vaginal wall and the anterior rectum right here. And this was seen on numerous findings. She had intermittent stool from her vagina, but the fistula is small. It wasn't like our previous patient. So just a reminder that MR can show us these with better soft tissue resolution. That's it. I'm gonna stop sharing screen.
So this is a patient, pre-liver transplant, prior negative imaging. And so we got this, just the routine screening.
Don't like the left portal vein and its branches.
Yeah. What do you think?
PIV, yeah.
Yes, exactly. So yeah, this is, and then I'm gonna share the diffusion because I think it's helpful. Right there.
I think also this is a nice example of how, like, a lot of times when you have this extensive TIV, it's not very vascularized.
Yeah, there's actually, right, go ahead.
Hepatic artery is like not able to, it has to supply the liver. See, that hepatic artery looks nice and robust, so the tumor is not going to get much of it.
And then the T2 is also, I think, very helpful. A great illustration of Aarti's T2 Evo Gray.
Nice. So are they going to go for here? They've, they even, well, I think if it's this extensive, they can't do Y90, but do you know what they're going to do for them?
The patient, I'll share with you offline what happened.
No worries. I was just curious because if it's like just on one lobe, sometimes they still will Y90 it, but if it's both sides, then they're worried about like inducing liver failure.
If you could start recording, I can share.
You know, another interesting thing I came across once is usually we see TIV in contiguity with the tumor, but there's only one case that I saw TIV, and surely it wasn't a blank thrombus separate from the tumor. The tumor was at the dome in segment 8, and the tumor thrombus within the right anterior or posterior branch, I forget now. It was real, expansile, enhancing, washing out, all those things, but there was no tumor in contiguity. I don't know if any of you have seen a phenomena like this.
Like here, there's no intraparenchymal tumor. This is all TIV.
Isn't there an infiltrating tumor in the left lobe? I thought it would.
I think it's all here. Let me reshare. Here's it's all in the
Vessels.
portal vein branches. Yeah, I mean, I don't see an intraparenchymal lesion. Do you?
No. Yeah. Yeah. So this is one phenomenon where you see only TIV, and maybe my patient had concurrent tumors, one TIV and one separate at the dome. Maybe that's what it was.
This actually came up in one of our national conferences. And I remember Claude talking about, when you have the situation, like somebody asked, like, could the tumor have started in the vein? And he was like, the tumor has to have started in a hepatocyte because that's where HCC comes from.
Right.
And so, but it could be a very small area and then it grows quickly into the vein and then it spreads throughout the vein. So it's still like, there is still some parenchymal thing, even if we can't identify like the actual, one area that it was.
Yeah.
But it's almost like academic at this point. But yeah, good case. Anyone else?
Aarti, I can show a case.
Okay.
Old woman who came with lower abdominal pain. I'm just going to start at the top. If anyone wants to talk about the findings. Can you hear me?
Yeah, I see a rectal mass and maybe an ovarian met or an adnexal mass too. I see two masses.
Okay, there's that and there's that.
Yeah,
and
bilateral adnexal masses
so
and then that rectal or anal.
Then we did MR. And this is diffusion. This is T2, T2, T1, and Crohn. So any thoughts?
It looks kind of bright on T2, like I'm thinking about a mucinous
Yeah.
rectal cancer with like ovarian mets.
Okay, anyone else wants to try? It's a good thought. So look at the T1.
I have another thought, an anal squamous cell. Like this one, I guess it's still, I think it's more centered in the rectum. So you wouldn't consider this anal.
It's kind of anorectal is what we thought. But if you look at the T1, and this is in retrospect, of course, the clue was that the mass is actually not iso-intense, but slightly hyper-intense.
How about melanoma?
Yeah, that's exactly what it turned out to be. It turned out to be an anorectal melanoma. And they actually called the ovarian, they just called it melanoma. They didn't say it's METS, but that's most likely what it's going to turn out to be.
What was the T1 signal intensity of the adnexal?
Well, we don't have it because we only did for the rectum. So that was it. But that was what it turned out to be. It turned out to be melanoma for both the rectum as well as bilateral adnexal masses. So a couple of things that I just, one is that primary ovarian malignant melanoma is extremely rare. They are mainly, metastatic. And for the rectum, most anorectal melanomas arise from the dentate line. And 65% of them are located within the anal canal or at the anal verge. This one was huge, so it's kind of hard to say where it came from. So the two stains that our pathologist spoke about were SOX 10 and MART 1. So I just basically looked up, and both of them are supposed to be pretty specific for melanomas. And both these tumors were positive for both these stains. So that is it. It's just
Kedar, the ovary was on pathology?
Yes.
Oh,
yes,
okay, okay.
Yes. Because everything was path proven.
Oh, okay, okay.
I've just never seen an ovarian one before.
Yeah, it makes sense to me that the melanomas are more from the anus and the anal verge because it's like skin, but why the dentate line? That might be a question for a pathologist, but I'm just curious if you.
This is quick Google search. So
Okay. Maybe there's more melanocytes at the dentate line to mark it off or something. But anyway, okay. I'll drop the question.
So this is a patient with pelvic pain.
T2 shading. Do I see T2 shading there?
Yeah. Tell me.
I spy with my.
What?
You know the game that you play, I spy with my little eye something, and then I spy with my eye, T2 shading.
Okay, what else do you see?
Adenomyosis, perhaps. The uterus junctional zone looks markedly thickened.
Right here.
Yeah.
Okay, and here.
Torus, yep.
And here. Okay, good.
Torus uterinus as well. There's T2
Good. Yeah.
tissue there. This is a disease which keeps giving, right? So
that's
the more
right.
the more
that's
you
exactly right.
Okay,
yes.
okay. Another location.
Yeah.
Well, I'm not too sure, but the urethral wall doesn't look.
Urethral wall.
But maybe I'm overthinking it.
Urethral wall. I think the
Maybe
I
that's
didn't see
okay.
anything on the urethral wall, and during laparoscopy they don't look at that, obviously.
Yeah,
so
that's-
I couldn't tell you if that was
Okay.
real or not.
Yeah.
I have
Okay,
one more
all right.
comment about the bowel. It looks like
Yes.
they're like clustered, almost like there's like a closed loop obstruction in front of the uterus.
Oh, the here?
Yeah.
Yeah.
Oh, that's a great point.
Yeah,
Which endometriosis can induce because it can cause scarring and bowel obstruction.
Yeah, I don't remember if this patient has small bowel disease. I don't think, but I'll double check. Okay, what else?
Always look at the rectal wall.
Yeah, and what do you
There's
think
like a
about that?
mushroom-
Rectal
Mushroom
involved.
sign. Yeah.
Yes, yeah,
There's
right?
a mushroom in the rectal wall.
Right here. Good, yeah. Just another beautiful case of loads of DIE. So yep. I'm learning. I like endo now. I didn't used to, but now I do.
Yeah, I just find it sad because we see endo incidentally so many times.
Yeah.
You know, I mean, and again, this disease is still a huge enigma, right? We don't like patients can be symptomatic with fewer lesions or asymptomatic with a lot of disease. So I don't think we still have a good hang of it on imaging in predicting, patient symptomatology. A lot of work to be done.
I have a question. Anu, last week when you showed the bladder endometriosis, you said that MR is very sensitive for endometriosis.
Yes.
And I think that it is in the pelvis, but I find it not sensitive for like peritoneal disease detection. Like they say, like on laparoscopy, they see a lot more endometriosis. And I've also heard some people saying they have an endometriosis protocol. So I'm just curious what you guys think about that. Like, have you found a better way to see the other tiny implants? And do you have a protocol, like a specific MR protocol?
So not for bowel, Aarti. I agree. GI endometriosis is still challenging. MR. There is a paper where they've done on 3T. They've done MR enterography and tried to show lesions, but these can be very subtle, and you can only imagine even with antiperistaltic agents. Serosal deposits can be really hard. So I think laparoscopy still scores over MR for bowel endometriosis or peritoneal disease. I don't think we've reached there yet where subtle implants we can't pick up. And then the other question is, unless these patients have bowel obstruction or tethering and symptomatic bowel obstruction intermittent, do small implants really matter? So that's the other question. But we don't have a specific protocol. That's the short answer to your question.
Cool, thanks. Okay, anyone else?
I can share a quick case if you want.
Yeah, sure.
This is two same patient, two cases separated in time by about 2.5 years. This was done as part of the bottom one is the earlier one. It's a CT urogram. And I'm just showing you the, looks like relatively early post-contrast phase. It's, it was done for hematuria, and that's not what's interesting about the case, but there were two reasons for hematuria. This one, which was a calculus, and this one, which ended up getting a cystoscopy and was a low-grade papillary neoplasm. And so what this was, though, was there was an incidental finding, which was a good call by a colleague. And we've seen this sort of thing before. And I'll just scroll up and see if anybody says anything. Maybe the coronal. Let's see. Do I have a coronal? I've got a coronal here. Are you guys still there? It's pretty quiet.
Yes,
We're
still
here.
here. Still here. And all of us are focusing, Steve.
All right,
They're
I'm
focusing.
gonna stop on it.
Oh, there, yeah, the thickened colon,
Right.
transverse
So
colon.
if you're not in the habit of running a colon and having a pretty low threshold of sensitivity for calling something in patients of the right age range, you know, anybody who's over 50, just say, if you haven't had a colonoscopy, it's time to get one because I don't like this, right? So this is 2.5 years later, and I'm doing a staging exam. I gotta get the next one over. Look.
Oh boy.
Oh boy, right?
Yeah.
But you're saying they called it on the first one,
Yeah,
but the follow-up didn't happen.
right. No, exactly. It wasn't attended to. I don't know if it had to do with COVID or distracted by other things, but this turned into this. And I mean, fortunately now there's no, you know, nothing in the liver. I didn't see anything metastatic disease. I'm a little nervous about the busyness of the fat leading out to the omentum here, and then some of the mesentery, but I actually discussed it with the surgeon, and probably that's going to get taken care of.
Yeah, that's an important point, not to call that peritoneal disease if it's like direct extension, even if it looks dirty and fuzzy, because it's still like local extension.
Yeah, they would. In transverse colon, she was saying they frequently will go after the transverse mesocolon and the omentum along with, because it can be a site for local disease, but not peritoneal spread necessarily.
Yeah, I think there's some scary statistic about the number of follow-ups that are not done.
Right. And you know, we've talked in my department about having a follow-up manager system that's more robust and better than we have. It's something that, you know, a radiology department on its own probably can't invest in, but a healthcare system really could do a lot in that regard, and have like nurse managers and make sure everything's sort of bird dogged and everybody's getting the care that they need. If you want to achieve sort of excellent population health, you definitely want to approach it that way.
Yeah, I know a few people starting a company to do that. So we'll see. Okay, Nelly, go.
This is a patient with recurrent RCC. Was treated with tyrosine kinase inhibitor. Incidental finding.
Small bowel and
lipomatosis.
yeah.
Wait, what? Sorry, small bowel what?
Lipomatosis.
So this is lymphectasia of the small bowel due to
Ooh.
tyrosine kinase. So this is a radiographics paper on drug-induced complications. And so this is it's a side effect of tyrosine kinase inhibitors, and they present with submucosal fat. They can get thickening, numerous hypoattenuating lesions, like we saw on this case. So it doesn't. It's just something that that can happen. It doesn't necessarily cause complications, but explains some of those bizarre findings in the bowel.
I think this is a cookie favorite.
It is. Yeah.
So wait, Nelly, you said they won't have symptoms, and then they'll just leave this alone.
Yeah. So and it's related to TKIs.
Do we know if this is reversible or permanent? Like once they stop the drugs, does that revert, or we don't know?
I don't know.
Yeah.
I don't know if it's reversible.
Maybe not. It looks like it's an anatomical change. Who knows? Need to read.
Yeah, I have to
remember a
look that
long
up.
time ago, Steve showed a case of lymphangiectasia in the mesentery that was treated
Oh,
with some
right.
kind of other,
FGFR receptor inhibitor.
some other.
Yeah.
Very cool, Nelly. Okay.
Thank you, everyone.
Thanks.
Thanks all.
Bye.
Bye, everyone.
Bye.